Endocrinology Grand Rounds. Dr. Khan, the Calcium Center Director, will be introducing our speaker today.
Good morning, everyone. Thank you so much for joining us. I'm delighted to present Dr. Azeez Farooki. He joins us from Memorial Sloan Kettering, where he is the attending physician and clinical member of the Endocrinology Service. He's also a professor at Weill Cornell Medical College. So his accolades are too numerous to go through, but include his specialty in bone disease and cancer patients. And he has authored numerous book chapters, articles in the New England Journal of Medicine, Diabetes Care, JCNM, among so many other things. And you'll be discussing cancer and bone loss, antiresorptive and anabolic osteoporosis therapy. Thank you.
Well, good morning, everybody. And thanks very much for having me out here. It's really lovely to be out here in Cleveland with you all. And special thanks to Dr. Khan for getting me out here. So we are going to talk. You guys are early birds. Boy, I'm impressed with the early start time. It's surgical start time here. So let me see. So we're going to talk about what I live and breathe. I'm not an oncologist, as you just heard. I'm an endocrinologist, and I just happen to live with those oncologists that are kind of like the annoying roommate for me sometimes. So there we go. I'll just click it. Yeah. Okay. So today, wanted to cover a lot of ground actually. And so for one thing, wanted to talk about all the data with anti-resorptive drugs that we know and love in cancer, and kind of focus on a case in breast cancer and then prostate cancer. And I have a couple of just questions to ponder here. Question number one is, what osteoporosis drug has been shown to improve survival with an absolute benefit similar to adjuvant chemotherapy in postmenopausal breast cancer patients? And number two, in prostate cancer, do most clinical fractures result from bone metastases or from bone fragility? And finally, we'll get to the intriguing part of the talk, the anabolic agents, and I'll show you some data from a pilot trial that we did, just 10 patients, but in patients with multiple myeloma given romosozumab. So here we see, this is sort of a classic slide, bone and cancer, about the rapid bone loss that can occur at 1 year from various anti-cancer therapies. And you can see here that premature menopause due to chemotherapy in one study caused a ton of bone loss, sort of like pulling the rug out from underneath somebody. And then we have ovarian suppression, which is AI therapy plus GnRH agonist therapy. Then we have ADT, bone marrow transplant, and AI therapy. Do you guys see any graft versus host disease patients that they often, boy, they have a perfect storm, malabsorption and inflammation and you name it, they really have a perfect storm. Now, immunotherapy, I think it's really, there's been some studies out there, and we need more data to really solidify what the deal is with immunotherapy. I think probably there is going to be an increased risk of bone loss and fracture from the limited data we have. One thing to just also mention is I think just clinically, when we see weight loss in somebody with osteoporosis, it often causes bone loss because of that osteocyte mechanosensing function. And that definitely is an issue in cancer patients. So I tend to want to take a global perspective here. And if I see somebody that has any of these issues, that might be not diagnosed, I try to refer them and try to push for that, to be figured out. I mean, even in a patient who you might see that has depression, anxiety, and is losing weight loss from that, certainly it's a good idea to address it for their bone health and beyond. All right, so here's the question I was asking, and this is Stephen Paget, who said that when a plant goes to seed, its seeds are carried in all directions, but they can only live and grow if they fall on a congenial soil. So the cancer cell is the seed and the bone as the soil. And you can see here that this soil on the left is barren, and the soil on the right is being turned over or plowed. So we'll come back to this analogy later. And antiresorptives, are sort of tons of data in our patients with cancer. So by this, I mean bisphosphonates and denosumab, and both in non-metastatic setting and advanced cancer setting as well. So you can show, and actually I have a shout out here to Dr. Ramchand Savashini's great study in JCO that really added to the literature here, showing denosumab could help prevent bone loss in ovarian suppression patients. So both with in the setting of cancer in the bone, that's another situation where the dosing frequency is higher. And there's been some de-escalation studies recently to be able to give it instead of once a month, every 3 months in that setting. But we're going to focus more here today. So here's a case just to get us thinking a little bit. So this is a simplified case, but 52-year-old lady, newly diagnosed breast cancer with osteopenia, and she's going to start an adjuvant aromatase inhibitor therapy. So she had a chemotherapy-induced menopause 1.5 years ago. Let's say that she has osteopenia, no history of adult fractures. She did have a maternal hip fracture, and her FRAX calculation has been below threshold. And there are no secondary causes of bone loss determined for this patient. So the question is, what should we do for her? And aromatase inhibitors, the mechanism is shown on this slide, and there's 3 of them. And these are the standard of care adjuvant therapy for postmenopausal breast cancer patients. And they're continued for up to 10 years. So these are really ubiquitous use. And thankfully, usually we can block the bone loss with bisphosphonates or denosumab that these drugs induce here. So they take that little bit of postmenopausal estrogen and make it 0, and that increases bone turnover and bone loss. Now, SERMs, that should be contrasted. An interesting point here is that in a postmenopausal patient, a SERM, as we all know, is weakly bone protective. But in a premenopausal patient, be it tamoxifen or raloxifene, it is actually acts as an estrogen antagonist, and there will be some bone loss that's brought about by that agent. And we can see here that the aromatase inhibitors cause bone loss. The slope of the bone loss is most pronounced over the first couple of years, 2-3 years, let's say, in the dashed lines. And in these studies, there was also tamoxifen being used, and tamoxifen is the solid line. So you can see the SERM is causing some bone gain, whereas the other drugs are causing bone loss. And when you compare tamoxifen to aromatase inhibitors in these studies, you can see that there's a difference in fracture risk in the majority of these studies. But all you critical people, smart people out there are saying, well, that's not really fair. You're comparing a bone protective agent, tamoxifen, to something that could be harmful for bone. So do we really know that one is harmful or not? And so we do have a sense of this, and I'll show you some data on that. But you can see here in this big study, the ATAC study, which I'm going to show you a little more on, there was large amount of bone loss at the spine and hip in these women who are mean age 64. So when you stop the aromatase inhibitor at the 5-year mark, keep in mind they're often continued for 10 years, you do regain some bone, so thankfully. And also, more importantly, the fracture risk, which you can see here, decreases, right? When the drug is stopped at the 5-year mark, the fracture risk goes down. So that's definitely, reassuring. I think we can mention that to our patients as well. And one other conundrum that comes up here, I don't know if you guys get these patients referred, but these ovarian suppression patients are premenopausal women that are put on Lupron and AI, and they can lose a ton of bone density, over time. And you can see that here. The good thing is that if they're quite young and you stop the suppression therapy and they regain their menses, then bone does come back. The bone density does come back. But really what causes the dilemma is if there's future pregnancy in the cards, you have to deal with the bone binding affinity of bisphosphonates, zoledronic acid, and then the reversibility of denosumab. So I don't think we have a definite answer for these patients, multidisciplinary decision making, but it's all you basically from the oncologist's point of view, right? So you might give a very, the last thing you might give is denosumab for a short amount of time, and then you don't have to worry about a severe rebound phenomenon, and then sort of plan the pregnancy in light of that. Okay, so now I want to show you quickly this study that sort of made my life complete because it was a well-designed, prospective, randomized, double-blind study. And they randomized to denosumab or placebo in these postmenopausal hormone receptor positive breast cancer patients receiving aromatase inhibitor. There was no metastatic disease. These were early stage patients. And so this aromatase inhibitor was being given as an adjuvant therapy. Anybody know what country this is for extra credit? I thought it was Delaware myself, but I was wrong. Somewhere in Europe. You guys are Americans, clearly. So yeah, that's right.
It's Austria.
Oh, there we go. Who did that? Who's the?
Mario Skugor, yeah. I'm right then south of that.
Yeah, it's where's sorry, I didn't catch where are you
I'm
from,
from
sir?
Croatia.
Oh, there you go. All right, you got us there. Yeah, very good. You get the extra, you get the prize. So yeah, that is Austria, and this was the ABCSG18 study, yeah, it was just a well-designed study looking at fractures as the primary endpoint. So from our perspective, we needed this. They also looked at some very intriguing things: this bone met-free survival and overall survival, et cetera. So what this showed was that, number one, there was a higher risk of fractures than we thought in these patients. And I should add that they randomized even people with normal bone density to get denosumab. And even though that ruffled my feathers, that was the right move here in that these patients were at risk and they did significantly benefit in terms of less fractures. So, something 16-17% risk of fractures at 5 years, considerable risk, and that risk was cut down by denosumab. And you can see here that these fracture reductions was very intriguing. We wrote a letter about this to the Lancet, and these fracture reductions were even in people with normal bone density and young people, right? Because we think that age should protect you from being at high risk of fractures, and so should the normal bone density. But still, these hazard ratios were pretty close. Now, the caveat here, one more thing to mention: these were all Austrian or Swedish patients, and I think how ethnicity modulates fracture risk, I think, is debatable, but that's just something to keep in mind here. So now to talk about this adjuvant effect of bisphosphonates, this thinking had been around for many, many years, and there was different mechanisms proposed here. Was it the effect on gamma delta T cells? Was it an anti-angiogenic effect of the drugs? And there were many randomized trials, believe it or not, with clodronate, et cetera, that were looking at this. And so these mechanisms, to me, were the simplest mechanism. Actually, once there was denosumab data, was that there was a common effect on the bone microenvironment, and that seems like intuitive to me that's got to be playing a role, because we had data from 2 different classes of antiresorptives that there was some adjuvant benefit. And so this story is complicated, like most things in medicine. And we still don't know exactly, I think, the mechanism of what is driving the adjuvant benefit 100%. But here is a slide from the eminent Dr. Teresa Geiss. This is an old slide now, but I think it's very relevant. If you look here in the premenopausal bone microenvironment, these disseminated cancer cells have nothing to sort of fuel their progression. And so the soil is not fertile for progression of these disseminated cancer cells with estrogen around. But If you go to the right side of the slide and the postmenopausal environment, you see that the osteoclastic bone resorption has various mechanisms, and one thing is that's invoked in sort of the vicious cycle of bone metastases is that osteoclastic bone resorption liberates these matrix-derived growth factors, TGF-beta, et cetera, that could feed back on these dormant cancer cells in the marrow and lead to activation. So if you think of it as that's a more, dormant soil, not fertile, and this is a more fertile soil, the osteoclast being the plow. So the punchline here in this story is that this big analysis from Europe in 2015, 19,000 patients from these adjuvant bisphosphonate trials, they had such a good amount of patients that they were able to tease out an effect here. And the treatment duration mean was 3.4 years. So the bisphosphonates in these adjuvant randomized trials were largely zoledronic acid, but they had other regimens that are not available to us, like abandronate 50 a day, oral pamidronate. And unfortunately, there was so little data with oral bisphosphonate that we really couldn't say anything. We don't know. There was a reduction in fractures, as we would expect. And so what they were able to show is that in postmenopausal patients, but not premenopausal, the absolute benefit, this is a survival benefit, regardless of estrogen receptor status, it was similar to that of adjuvant chemo. So this is really, I think, important data. And by the way, postmenopausal was natural or induced by GnRH agonist. And what drove this benefit? What drove this adjuvant benefit? It was actually driven by less bone recurrence over the first years of the study. And, you might wonder, because, we know that probably bisphosphonates could have some pleiotropic benefits in the Horizon recurrent hip fracture study. There, for the fellows out there, there was a mortality benefit that was able to be shown from multiple causes. It wasn't like one thing. But in this data set, there was no difference in non-breast cancer mortality. Now let's go back to Austria. And our friend's going to take us all on a vacation to Croatia while we're at it. But there was a...
You guys are welcome to come.
Oh, thank you. So there was a improvement in disease-free survival, which means less recurrence in this Austrian study that was pretty similar, this absolute difference of 3.1%. That was in these patients initiating aromatase inhibitors in this study. So this is a double benefit that I like to discuss with my patients because it may help some people make the decision to take bone protective therapy. And, some people are minimalists and they say, keep your drugs, I don't want it. And other people say, give me, I want to, yeah, give me that. That sounds like something I want to have, that kind of benefit. Those are the maximalists. And just following up on the Austrian data here, this was published in 2022. They had a very good safety profile in terms of ONJ and atypical femur fracture in this Austrian study, where denosumab was supposed to be given for 5 years. And when the question is what happens when you stop it? Well, there was no definite protocol for what to do when you stop it. So there was an increase in multiple clinical vertebral fractures, numerical increase here, you can see. So that publication did not get too deep in the weeds with this, but I will point out here that there was an improvement in bone met-free survival, and there was an improvement in fractures in this study. Now, all that being said, the Austrian study was contradicted by a study from the UK, and that led to the American Society of Clinical Oncology telling us that bisphosphonates should be the adjuvant therapy that you discuss with these patients if you need to, if the oncologist feels that they would benefit from an adjuvant therapy. Bisphosphonates should definitely be considered, and they're not substitutes for standard anti-cancer modalities. But they did not recommend denosumab because the second study from the UK, which was in a different patient population, was negative. It did not show any benefit with incidentally higher dose of denosumab, the XGEVA dose. So back to our patient here, this patient with mild osteopenia who's starting an aromatase inhibitor. The first bullet I have to say, I think I've been mulling this over. I don't think the Frax is actually appropriate for a patient who's at risk for rapid bone loss, right? So we're not going to worry about the Frax. If you wanted to, you could click the rheumatoid arthritis button. But if you're worried about rapid bone loss, Frax is irrelevant, really, right? So this patient had a chemo-induced bone loss, chemo-induced menopause, sorry. So definitely at risk for large bone loss. And then you want to talk to them, as I was getting at, are they a maximalist, or are they, give me everything you got, or a minimalist, like, nope, I don't want it. And just the summary here is that the bisphosphonates have this adjuvant benefit and should reduce fractures. Denosumab, we have conflicting data. And then the question comes up, well, if these patients are going to be on aromatase inhibitor for 10 years, what do you do? And I would say, case-by-case basis, but of course, the dosing intervals of bisphosphonates, after you give a sufficient, amount of bisphosphonate, you can back off on the dosing interval. And I follow bone turnover markers and bone density in that regard. But the strict adjuvant regimen is 4 milligrams every 6 months for 2 years. So this is our summary here. Whoop, got somebody's Outlook. Okay. This patient's at risk for bone loss and at risk for fractures. First choice would be zoledronic acid, and the patient wants to know, well, would that hurt my cancer in any way? Actually, no. It would prevent bone recurrence and help you live longer, hopefully. Let's go to prostate cancer quickly. So androgen deprivation therapy, as we all know, there are new flavors of this. There's androgen receptor inhibitors, and there's abiraterone, right? So I'll show you some details about these other agents. But one thing to point out is that the ADT user has 0 testosterone, and because of that, there's 0 estradiol. So these guys truly get hot flashes. And because of that 0 estradiol. And there was recently in 2026, a study from the UK where they gave these men a HRT patch. And they were able to show a reduction in fractures, pretty decent reduction in fractures, as we would expect from estrogen. We know that that is a benefit in women. And actually, incidentally, SERMs also do prevent bone loss in prostate cancer patients, but there was never an FDA approval, probably due to DVT risk and trial design and so forth. So just something to keep in mind. Like, I had a patient who developed ONJ on denosumab. An oncologist sent the patient to me. So now what do you do? Well, if the patient's not at super high risk for DVT, giving them a SERM or estradiol would be an option for, I think, for that ONJ patient. And here we see the fracture risk over 1 year, patients taking GnRH agonists for less than 1 year, no GnRH agonists, and GnRH agonists for greater than a year. So thankfully, if you're on it for less than a year, the curves kind of come back together with the fracture risk. And you see that there. But it is considerable risk. 26% of patients from some recent data over 10 years had fractures. And actually, the punchline here is that most clinical fractures do not result from bone metastases in these prostate cancer patients. They result from osteoporotic fragility. So it's really something important to keep in, pay attention to. And you can see that the bone loss from ADT happens pretty quickly, over 6 months. It just pretty rapidly in this study, which was comparing chronic ADT to acute ADT, started less than 6 months ago. So it's something to get on top of pretty quickly. Denosumab has another randomized trial showing fracture prevention in this crowd, in this ADT-treated cohort of men. So as we would expect with a potent drug. Now, going back to the androgen receptor inhibitors like enzalutamide, these drugs, they not only increase fracture risk, but they increase fall risk. And so apalutamide and enzalutamide cross the blood-brain barrier, and that might have a role in what's driving the fall risk in these patients. So I don't know about you guys, but I like to refer patients to, physical therapy, physiatry, whatever it is, to try to tune them up to lower their risk of falling. And now if we go to abiraterone, abiraterone is often given with prednisone. This is the classic endocrine steroid synthesis pathway, and then you get this block and this shunting. So that's the reason for the prednisone, but you can ask the oncologist to drop the prednisone dose down to 5 milligrams QD, or if the patient needs better blood pressure and potassium control, 2.5 BID. There's some data on that. So here's a case, a prostate patient. This is a 70-year-old guy. He had chemo. He was on Lupron, is on Lupron, zero testosterone, no surgical medical history to suggest calcium malabsorption, had a couple of doses of denosumab, but it was lost by the wayside. Alkaline phosphatase very high, corrected calcium a little bit low, vitamin D not too shabby, GFR 50, and he's got some osteopenia, some fractures on the CT scan of the L5 and left rib fractures. He has diffuse sclerotic osseous metastases. These are his medicines. So what's the next best action? Do we want to give more vitamin D, stop the PPI, give zoledronic acid, check labs? Well, I'm an endocrinologist, so I like to check labs. so the patient's definitely at risk for, a hypocalcemia, I would argue. And that's because of low GFR. It's because of this osteoblastic sort of hungry bone mat burden that a lot of these patients have, which is probably contributing to his calcium just hovering at the upper limit of normal. So this has been described in prostate patients, this sort of hungry blastic bone met picture. And the fellows out there, who are the fellows? You guys have already seen denosumab-induced hypocalcemia, probably. Yeah, it can be very severe in these prostate patients. And, we published a case series on it. It can happen with zoledronic acid too. But, in general, the way I look at it is that if somebody has baseline secondary hyperparathyroidism, their calcium metabolism is already stressed, right? And you need to try to correct that if you can by giving calcium and calcitriol and whatnot to try to lower the risk of precipitating severe hypocalcemia, if that makes sense. And so the prostate patients, basically, as long as their testosterone is below 200, they are at risk. So, you could argue to treat them for that entire duration, or, of course, with a bisphosphonate, you can give a holiday at some point. If the level recovers, then you're better off. Oh, getting a reverberation. Okay, all right. And sometimes there's a confusion about in oncology circles that zoledronic acid is only approved for castration-resistant cases, but of course you can give it to prevent bone loss and to prevent fractures in these patients that do not have castration resistance. So, a couple of other pearls here that these neuroendocrine prostate patients can secrete FGF23 or ACTH. These are rare situations, but they can happen. So here's sort of our grid of approved indications for zoledronic acid and denosumab in these cancer patients. And the key point here is just that this endocrine therapy-induced bone loss, you don't need osteoporosis to give zoledronic acid or Prolia every 6 months to these patients. This is also an approved indication here. Okay, so let's go to anabolics now. Okay, so there's very little data, but I'll take you through some of it here and my thoughts on it. And you know, there's been these theoretical risks of anabolics that I've worried about a bit over the years. And thankfully, we're getting more and more basic science data on this subject. That, you know, Sabashini and I are part of this group that we have a lot of basic scientists that are very interested in this, and so it's really cool to have them and, you know, get their thoughts and design perhaps trials with their help. But these were the kind of the risks that by giving a drug with the opposite mechanism of antiresorptives, which we know do such good things, could you do something not ideal to these patients? And so here's sort of in the bone what you know, the tumor does is that classically the tumor is going to turn on bone remodeling, bone turnover, and again, you get liberation of these bone-derived growth factors, bone matrix-derived growth factors that go feed back on the tumor. So that's kind of the vicious cycle that's interrupted with antiresorptives. But what is really interesting is that, you know, you would think that giving PTH would not be a good thing. But in this study from Dr. Joy Wu's group from Stanford, they were able to show that, you know, this is a mouse study. So they gave PTH to the mice. They had to get prior auth from the mouse insurance company, and it was a big pain. But so they were able to show, though, that the PTH1 receptor on the breast cancer cell was activated, and this would reduce PTHRP expression and decrease bone mets in these mouse model of breast cancer. And Rochelle Johnson is doing really interesting work as well on this. Another just thing to point out on here is that it's fascinating to me that these disseminated tumor cells, which you see here on the lower right, are in close communication with osteoblasts. And the osteoblast actually transfers calcium to these disseminated tumor cells via gap junctions. So, you know, I think there's more to this story that we're still figuring out. PTH analogs have, you know, sort of different preclinical data and limited clinical data, but, you know, I would use these in certain patients. Like I've used a PTH analog in a myeloma patient who was fracturing despite, you know, standard of care. God bless you. So this study from Australia sort of inspired us to do our own study where they gave it to teriparatide for 1 year to patients with severe osteoporosis who were in pretty bad shape. And they actually had a good result here. There was no new fractures. They got an increase in QCT bone density. And there was no activation of lytic lesions, let's say. Second study is a study using teriparatide in patients with ONJ. You guys know about this study? You know, I think it's pretty, it's an 8-week duration trial that was published in JCO, the best cancer journal. And there was a lot of cancer patients in this study. They did not have active bone metastases, as far as I'm able to tell. But what they were able to show was that there was an acceleration of ONJ resolution. So, you know, clearly there is a, you know, beneficial effect here, of teriparatide, and there was nothing bad that happened here. And the final scenario would be just hypopara patients. Of course, a lot of them have a history of cancer, right, because of the neck surgery. But, you know, these patients were excluded if there was active malignancy within 2 years of trial design, based on the trial design. So romosozumab, you know, we had been thinking about this, and this is a simplistic way to think about it, but it's certainly, you know, in myeloma, you have this, you know, inhibition of bone formation, increase in bone resorption. So it's sort of the prototypical malignancy to try to give romosozumab. We had some animal data from Dr. McDonald in Australia that, you know, it does good things. The romosozumab, the sclerostin antibody, did good things in the mice. So, and furthermore, there was a unmet need in that, you know, the existing antiresorptives decrease event rate by 50%, bone events, skeletal-related events in this cohort. And just going again to just show you with myeloma, this is what in oncology is a composite endpoint. It's called skeletal-related events, and this is when there's advanced cancer in the bone, all the bad things that can happen. And so you see here that in the first 3 months of this study, where actually they were comparing denosumab and zoledronic acid, there was absolutely no difference in the hazard ratio, but there was a tremendous, rate of skeletal-related events. And interestingly, I mean, often the antiresorptive is really delayed because the dental clearance is a big thing in oncology. They must get dental clearance, rightly or wrongly. And I'll say one more thing here is that if you look at the rate of ONJ in this study, the rate of ONJ was higher with Xgeva 4% versus 3% with Zometa. So that led us to plan this study where we gave romosozumab to patients with active myeloma who were postmenopausal women with osteoporosis. So we gave the drug on label. The drug company was not interested in funding this study, Amgen that is. So these patients were getting sort of standard of care PET CT, and then we got a DEXA. And so this is that study. And again, postmenopausal women with active myeloma and osteoporosis. So we looked at bone turnover markers, bone density, and we chose a lytic lesion, one sort of target lesion that was greater than 0.5 centimeters in diameter, to see if there was any effect in sort of filling in that lytic area. And actually, unfortunately, in that one spot, there was no change. So we are looking at sort of this CT segmentation analysis that's out. That's a very amazing thing too, where you can check the Hounsfield units difference at any port in the skeleton. So we're trying to get a sense of that in collaboration with the Arkansas group, actually. So you might wonder, did the romosozumab do anything negative to the myeloma? It did not. There was one patient that had developed progressive disease in this study, and that subject, that's actually my patient, but it was not thought to be due to the romosozumab. My oncology colleagues said, no, it's not, that's not what it was. And the patient completed the study, got zoledronic acid, and then had 2 new osteoporotic fractures. So, you know, that might, I've tried to talk her into PTH perhaps. She had already had a good amount of zoledronic acid as well. She has severe osteoporosis. Here's the data with P1NP at month 1. So that was our primary endpoint to show an anabolic effect, and there was no real significant change in CTX. We also, interestingly, looked at other bone formation markers and DKK1. So, you know, the part of the rationale for developing this sclerostin, DKK1 antibody, the Angecia drug, is that there's a feedback increase in DKK1 when you give romosozumab for 12 months. But we didn't, you know, this is only 10 patients. We didn't see a clear trend like that in this data set. But that drug is, hopefully going to be more powerful and more effective than even romosozumab. This was our bone density data. So we were able to show bone density increase at the spine and the hip. The radius didn't cooperate, but the radius is sort of the highest precision error site, right, of any site. So you see here that these patients were previously treated with zoledronic acid, actually, which tends to blunt the anabolic response. And this is the final slide here, just to show you guys that the rationale for continuing study in this case, the risk of ONJ with romosozumab, there was one case in a patient with poorly fitting dentures that only had romosozumab. There was another case in somebody who had romosozumab followed by denosumab. So I think the risk of ONJ is less than especially if you compare to Zometa and Xgeva dosing. So we think there's rationale for future study here. We want to leverage that to try to study this, further. And so here's a sort of summary. One more caveat to tell you, you might say, well, I can use romosozumab, right, in patients with different malignancies, lung cancer, let's say. But the problem is that some of these metastases are themselves sclerotic, and that's because they have an increase in Wnt signaling in the tumor. So I think we have to be careful. You know, there's one study from Japan, preclinical study, which showed that it could sort of activate the bone mets in these breast cancer patients because these were Wnt dependent situations. And that, you know, there have been Wnt inhibitors that are trying to be developed in oncology. Of course, you know, when we give romosozumab, it's sort of focused in the bone tissue. That's where there is expression of sclerostin and maybe in the vasculature as well. So I think we still need a little more data to feel comfortable, but myeloma is really, I think, the prototypical malignancy for giving an anabolic. And so final slide here, I think the oncologists really need our help. If there's any out there, I don't want to throw them under the bus, but I think they have enough to worry about, and they really do appreciate the, you know, in-depth conversations we can have with patients about risk, benefit, and so forth. So thanks for your attention.
Thank you so much for that beautiful presentation. I also wanted to acknowledge all the oncology and rheumatology physicians who are logged in virtually. And the great thing is we do have time for questions.
Excellent. Yeah.
Thank you so much. That was a great tour de force and very where we are up to in the field. I had a question about what your take is on patients who have had thyroid cancer. Because often, you know, we are stuck with vascular risk, and so we don't give them romosozumab. And have you given patients personally, like the PTH and PTH?
That's a good question. Yeah, I mean, I think I've given one patient PTH who had breast cancer. That was, I'm thinking of metastatic breast cancer. But I think if somebody's NED, you know, for 5-10 years, you could do that. The only issue is that, you know, the radiation increases the risk of osteosarcoma a tiny bit, as we know. And you know, I think you'd have to just tell the patient, like, listen, this is an issue, but I think that your risk benefit is in favor of, since you have severe osteoporosis, to take something and just document that. If they're happy with that, you could do it. Yeah.
I guess just as a follow-up question, I mean, because the label for osteosarcoma was removed, is it the intrinsic cancer itself that can cause the radiation? Because I was just kind of confused, the whole blunt, like generalized negation of anabolics in these cancer patients.
Yeah, I mean, I think, you know, the beam radiation increases the risk of osteosarcoma, and whether giving teriparatide for 2 years increases that, I don't think it does, because we have the human data that didn't show any increase beyond the background incidence. But yeah, there is that tiny increase in relative risk from beam radiation. And I mean, if it's very localized, I don't think we have to worry about it too much. But the other kind of theoretical thing with the anabolic, you know, giving a PTH analog, was that, well, you're increasing bone resorption, and we know that anti-resorptive activity seems to be a good thing. So should we be doing that or not? And I think the answer is, if you really have a severe osteoporosis patient, that you should do that.
In terms of the calcitriol prevention of hypocalcemia, do you have kind of like a rough schematic of what you do? Because that is a dreaded complication.
Yeah, I mean, I would check, you know, anybody that I'm concerned about, the MAG, the PTH, obviously 25-hydroxy-D. And like, even if you have a CKD patient and their, PTH is running wild, is 220, you really, and let's say their GFR is around 30s or so, you really want to get the PTH under a little better control with calcitriol, starting 3 times a week, and maybe bug the nephrologist to get on top of it a bit better too, because sometimes that goes by the wayside. And I do think that's kind of a setup for disaster. But you could recheck the calcium 1 week after the antiresorptive's given.
Dr. Licata, do you want to unmute yourself and comment?
Dr. Licata, feel free to unmute yourself if you want to ask your question. I guess while he's doing that, I was really intrigued by the concept of giving the denosumab like for a couple doses for these high-risk patients. Is that something you do frequently?
Oh, was that based on which was that, the prostate or the breast? Or
The breast.
so denosumab oh yeah, that's right. That was regarding the premenopausal patient who
Yes.
wants to get pregnant.
Yes.
Yeah, boy, I'm kind of, to quote my chief, Mike Tuttle, I'm kind of making that up as I go along. I mean, it's debatable, but I think that, if you have somebody that, you got to stop the zoledronic acid, it depends on the duration that you're giving it, but at least a year, more than a year, I would say. And, if you're stopping the zoledronic acid 2 years before desired pregnancy, well, then, okay, you could, if you're worried about the patient losing bone, you might want to give denosumab for a short amount of time to those specific patients, because it's not going to have such a big effect.
On androgen deprivation therapy that you've given estrogen replacements, is it just a low dose patch? Have you had complaints of gynecomastia?
Yeah, that's a good point. Yeah, you do get gynecomastia. Yeah, I really haven't done that. I've been with the SERMs. I've gone with the SERMs when I've done it. But in that study that was just published in the New England Journal, they did get gynecomastia. Yeah, but really, other than that, it was pretty decent safety profile. That was pretty effective.
So wise tamoxifen would be, because that would help prevent gynecomastia.
Yeah, I mean, there was one old study with raloxifene as well. I think any of them could work. But that DVT risk, you really got to be careful in these guys that are older and immobile. So. Fellows, don't be shy, fellows. Yeah.
Another agent that I tend to use as well is Resentame for those who because it has a much shorter offset fraction. So yeah, for those that, or even the transition sequential therapy for Resentame is also.
That's a great point. Yeah, I mean, it's the least sticky of the bisphosphonates, and it'll come off the bone the fastest. So yeah, you could do that. It's a little weaker I think, in general, but yeah, definitely.
Thank you so much.
Thank you.
Thank you so much. It's great.
No, good. Yeah, there's a lot to cover is the
It's a lot
problem.
to
So many things that we can talk about. Yeah.
It's changing so fast, right? We're all using drugs.
Yeah, that's true too. The immunotherapy is definitely ripe for study. Yeah. Cool.
But yeah, this was perfect. And it answered a lot of our questions.